Hello and welcome everybody. I'm Christine Hancock, founder of C3 Collaborating for Health, and it's my great pleasure to welcome you. People are continuing to join, and a very good evening to people in Europe and good afternoon to North America and people from around the world who are joining us. C3 Collaborating for Health is a global charity headquartered in London, working globally for the prevention of chronic disease. And we have been around for 10 years. We've focused particularly on the risk factors that cause the major chronic diseases. But over time, we've also become aware of the vast amount of other issues that determine whether or not people are vulnerable to chronic disease. Social circumstances, environment, and gender are all incredibly important in determining the health outcomes and healthy lives that people are able to live. Our international seminars used to be breakfast seminars that we hosted in our office, and we were renowned for our excellent breakfasts, which I'm afraid you aren't going to get this time. And we used to have to wait until we knew somebody was coming through London, and then we captured them, kidnapped them, and asked them to do one of our seminars. And Professor Toulou's been booked for some time because she was supposed to be in London today for a major conference celebrating Florence Nightingale's anniversary. But sadly, she's not here. But one of the good things about having to do our seminars online is that we're able to reach far more people across many different parts of the world. So you're all very welcome. And we're looking forward to this seminar. We want, if you will, for you to stay on mute until the end, and we will mute you, so we'll control you. We are recording, and it will be available to all participants, as will Professor Toulou's slides, and the chat function is available. So please put down your questions as soon as you can. We have two wonderful speakers today. I'm just going to introduce at the moment Professor Sheila Toulou, who's a great long-term friend and who I'm delighted, sad that she's not in London, but delighted that she's joining us today. She is in many ways most renowned for the work that she's done in Botswana particularly, but throughout Southern and Eastern Africa on HIV/AIDS. And when I was thinking about Sheila today, I thought about how, and many of you won't be old enough to remember the fear and the horror of the early days of the HIV epidemic, when it felt like it was a plague, nobody quite knew where it came from, what was going to happen, and everybody was so scared. And then over time, we understood more about it. But one of the country that was probably most seriously hit was Botswana. So Sheila's work in Botswana has brought her justifiably many awards. And I think there are many lessons that we, particularly those of us in Europe and North America, who are facing particularly the COVID-19 epidemic, to learn from a number of the issues which generations earlier faced when there was such a frightening epidemic of HIV/AIDS, when we knew so little about how to prevent and how to treat. So, but tonight, Sheila's really here as a famous advocate of women's health. And last week, she was chairing a plenary session on the World Congress on Public Health, which should have been in Rome. This morning, I was chairing a webinar that should have been in Thailand, but was in my front room. But all of the problems around at the moment have enabled many of us to come together and listen to you now, Sheila. So we are delighted to have you with us.
Unmuting myself. Thank you very much. And let me greet everybody and say good morning, good afternoon, good evening, wherever you are. And if you happen to be in Australia and sleeping, well, have a good slumber, that we are here with you. So I want to thank you, Christine and the C3 Collaborating for Health members for putting up this. I think it will be a good, I wish I was there. I really would have wanted, especially now after being cooped up in Africa for the past, 7 months? I really would have wanted to be in London, but hey, next time we will be able to make it. So I want to also greet my colleague, Lord Nigel Crisp, my co-chair of Nursing Now, and also the people who are listening in, some of them the CEO and the members of the Nursing Now board. So it's really great that they're here. But most important, let me pay tribute to our colleagues, the nurses and the midwives who have passed on, who have died while giving care to some of their colleagues, and to really say that their legacy will move on, will live on in our hearts. I want to also pay tribute to those of you, the nurses and the midwives, and everybody else who is continuing to give care to some of our colleagues, despite the fact that sometimes it's under very stressful conditions where there is lack of PPEs. And indeed, a lot of our nurses fear that very stressor of having to be infected or bringing the infection back to their families. So as we're talking now, we really are hoping that we will see the end of this pandemic. And it is a pity that is happening on the very year of the nurse and the midwife, when the light was shining on nursing and midwifery. But my colleague, Lord Nigel, will be able to talk about it, the fact that we have extended the Nursing Now celebrations until next year, just to ensure that we do celebrate our nurses wherever they are. So let me have the next slide. Okay, so right now it's a talk with you. It's not based on a lot of research, but mostly a lot of anecdotal but easily replicable evidence of the critical lessons that have been that I've learned in working with nurses to promote gender equality through advocacy, through action. And indeed, as Christine has already said, the AIDS epidemic was the one that really showed us that women were more affected than males, and we had to do something as nurses. But I was there, so my thing is, I'm really sharing with you the personal experiences in my role as primary healthcare nurse. I like that aspect of the primary healthcare nurse because I'm with somebody who has just written a book. Lord Nigel has just written a book that it is saying health is made in the home. Hospitals are for repairs. And that's really a feeling after my own heart. I'm sure he'll talk about it. But in our expected outcomes is simply that those of you who are here will be inspired, especially the young nurses, to become leaders in their own preferred area of interest, but also in the global world that we live in. Right now, the world is actually, the COVID epidemic has shown that the world is connected. We are one planet and we cannot avoid it. Let me have the next slide. So the messages that are coming from the response of the COVID-19 pandemic is simply that we need public health for the future of humanity. And those of you who are, of course, talking about chronic diseases, you really know how the importance of public health in working with communities. So some of the lessons, the messages, especially that have been really emphasized last week in the World Congress on Public Health, has really been that, all this highlights our oneness and our interconnectedness as human beings. So we need global cooperation among us, the health community, as well as our leaders. But that can only come through our own advocacy and action. Secondly, that health professionals need to advocate for primary health care. It may have been launched how many years ago, 45 years ago, but it is still as relevant today. as it was then. So we need to ensure that the highest attainable standard of physical, social, and mental well-being becomes a fundamental right of every human being, wherever they are, and, regardless of whatever, their social standing or orientation in life. So we need to build strong community ownerships. Let me have the next slide. And really involve the local leaders, especially the leaders who are working with communities. We need to harness the power of proper collaborative international research. And I'm hoping that that's one thing that is going to happen. And to address inequities of race and gender. I know the Black Lives Matter movement has really shown how race matters, but it's still gender. Because in the ultimate, we are showing how it has direct impact on health, and therefore we need to advocate for that gender equality that our leaders promised us through the Sustainable Development Goals. So now all this is possible. I know in all these messages, sometimes nurses will look at that and say, well, how do we feature there? But it's possible by nurses and for nurses. And we have those lived experiences to show that leadership of nurses within the global context within which nursing exists. Now, what's that global context? Let's get the next slide. We have a lot of things that are impacting on nursing and primary health care. Poverty, natural disasters, man-made disasters, and this one's really made by men, real men, terrorism with armed conflict, mass displacement, and we have the epidemics. HIV/AIDS is not yet over. Ebola comes in and out, so it's not really yet over. And COVID is right here, is paralyzing the world, but we will get through it. So, but in spite of this, COVID has also highlighted the fact that we have very weak health systems and inadequate human resources for health, especially nurses and midwives who can be able to work at promotive, preventive, as well as the curative level. So we have also the lack of protection of human rights of women and girls and key populations. Most of the time when I talk women and girls, I include key populations because it's very interesting to some people. Women and girls, it's a very nice topic. Okay, they're vulnerable. But once you mention sex workers, and you mention drug users, and you mention men who have sex with men, then the morality comes in. But you see, those also have to have their rights promoted, and they should have access to healthcare like everybody else. So I got interested in primary healthcare and gender just from that human rights and gender perspective. Let me get the next one. So that what I'm going to tell you is really how I then worked with nurses since I was an academic, but also a researcher and an activist, to ensure that I involve them in gender promotion and ensure that everything that they're doing is based or has really a gender lens. So as an educator, I was able to get my own students, master's degree students, educate them in gender and HIV issues, and they became activists to the point where when now they were doing their research, all of them were doing research on HIV and AIDS and the gender aspects from their own communities. But the great part was these people then later became ministerial HIV coordinators, because when I became a minister, I decided that every ministry must be relevant and have HIV/AIDS coordinator so that we have responses to AIDS within that ministry. It didn't matter whether it was finance, agriculture, or whatever. I decided every ministry, AIDS is relevant for every ministry, not just health. So that these nurses then became ministerial HIV/AIDS coordinators at the very top level, next to the permanent secretary. So to me, and since all of them actually were females, it was really what more, therefore, gender equality, looking at that gender promotion. So in the research, we are able to document the impact of HIV on African women and use that as evidence at the ICPD conference in '94 and the Beijing conference in '95, because at that time, a lot of people, especially in the West, to them, HIV was a disease of homosexuals. But we're able to show that for us African women, it has nothing to do with that. It is more of a gender issue. So Indeed, nurses were able to document the impact of community-based interventions on HIV prevention for both men and women. Let me give you an example of how it helped in really, because when we're talking gender, sometimes we think just women and AIDS, women and girls, but men also matter. As a minister, I had already worked with students to document that there are places where men are more comfortable to go for testing than other places. We didn't know why or how, but we knew that the numbers, they were always great and they were happy with the care that they were getting. So when I became a minister, I put more funding into those places. For example, the Botswana Christian AIDS project, to just say, involve more men, call men so that they can come for testing and they can access ARVs, treatment and everything. Because of course we didn't want our men left behind. Women were the first to go in because they're thinking of themselves, they're thinking of their immortality through the children, but not so the males. Being male is not, being sick is not masculine. So we had to now look out for our males and ensure that they also access ARVs. So next slide. Now, we didn't want this to end just in Botswana. We are with my colleague right here, Nomhle, who can attest to the fact that the very first nurses, some of them nurse leaders in South Africa went to Botswana, because that was before the independence era. It was still within the apartheid era, so that we were able to educate, as part of the WHO Collaborating Center, we're able to educate nurses from Southern African Development Community. That's all the 14 countries except DRC. So that makes it 13, but a lot of the current nurse leaders actually graduated from our program, and some would therefore come as part of just the regional workshops and all that. But in there, we made sure that we integrated human rights and gender issues and encourage them to do curriculum design, planning, and actually evaluation, but also change the curriculum. Let me not say it was easy. When I advocated at the University of Botswana, before I became minister, to say we need to integrate HIV/AIDS into the curriculum, there was an outcry and people didn't want to do that, because I wanted not just the nursing curriculum, but every faculty, including engineering. So, but later they saw the value of that. We had to go out and be able to really do advocating. And therefore now we're actually influencing even the rest of Africa, especially SADC, to say, let's do that. Also, let's do research to produce better data for evidence-based decision-making, so that we were able to therefore show that power of evidence, not opinion. Okay, the next slide. Now, as a politician, I work with nurses because they were the ones we had, especially the community healthcare nurses. They had already documented what was happening at home level. For example, the fact that women were being disadvantaged, where immediately they get married, something that we inherited from the British, Lord Nigel, that once you get married, you are no longer a minor. I mean, you become a minor because your husband takes over. So we had that thing called marital power, and it made women so impoverished, because the men literally administered everything alone, and the women would be left with nothing. So, and that you can imagine the cause of poverty, the cause of stressors, even in fact, even mental health. A lot of women, some women were hospitalized, and part of the reason was where they would come up and there would be no cow because the husband has sold them without that person's knowledge or even consent. So we did agitate, and we got the abolition of marital power. We work with our fellow members of parliament from both the ruling party and the opposition, so that now women have equal rights in acquisition, administration, and disposal of property. And it also gave women that, inheritance, land rights, as well as personal rights. A woman could now decide to say, I'm going to have a tubal ligation with or without the husband's consent. Before, you could not. you had to have your husband sign for you. So also the domestic violence, that one is very straightforward. We're able to promote peace and security in the home, so domestication at community level. So for HIV and AIDS, the gender aspects were very important in that the decision had been that the women should be the first to access. Once we have free mother-to-child transmission services and free ARV services, women should be the first to access, and then everybody else, so that we then show the rate of mother-to-child transmission go down from 29% to 8% within 4 years. And maternal mortality due to HIV go down from 31% to 10%. So, but people can then say, let me get to the next slide, where people may say, well, yeah, but what about later? What happened? How do we know it was the nurses? We know it was the nurses because we were able to send a lot of nurses for specialized training. We were able to have nurses, nurse practitioners, be the ones to see the patients, to prescribe for patients, to follow up patients. And indeed, our adherence rates were much higher, like around 98%. What then happened was, after I left and became regional director, the training of nurses and the education went down. And we actually saw infant and maternal mortality rate, as well as under 5 mortality rate, double. Within the 10 years that I've been away, we have actually doubled the mortality rates. So I'm now advocating to the new president to say, we need to go back to nursing now, the Nightingale Challenge, and ensure that we train nurses in those great positions, more nurse-led clinics and all that. So it is really, the lesson learned has simply be that the world needs to invest in nurses and midwives. And there I am advocating that we need nurses that are well-trained, educated, and supported, to lower poverty, in fact, for all the SDGs. But most important, we need nurses to go in and thus lead political change. So the last slide is really more lessons learned. Let's have the last slide. It's really showing that we can, we've talked about leadership, but yes, nurses need that leadership, that training, that education in leadership. It is a journey, it requires skills, and nurses are brave and bold enough to travel it. Knowledge is power. We need nurse leaders who are research-oriented, who are able to advocate for effective gendered policies. We need to collaborate with other stakeholders in research, in advocacy, and especially that because it is a mandate of the ICN, the International Council of Nurses, say we need to do research in order to really be able to change the world. But we need to collaborate with other stakeholders in research, on social and other reforms. But most important, I usually say to people, health is a political choice. So include running for political office so that you can be there to make those gendered and human rights sensitive policies. So the last one is that as we are here, I'm hoping the nurse leaders who are here will be able to inspire younger nurses and even future nurses, those girls who may not have yet decided whether they want to be nurses or not. We need to be able to inspire them so that they can be those brave to bold role models who can be able to take off our mandate on gender equality and ending chronic illness. So with that, let me just say thank you so much for listening. It's hot in here.
Thank you, Sheila. We're probably jealous if it's hot, but thank you for inspirational talk with so many lessons from your experience in Africa that are still so relevant to the work in other parts of the world. And I think in that message about learning from other countries, that's very much what our seminar is about. It's also very much what Lord Nigel Crisp has been promoting through his works for many years. So Sheila, there's a question in the chat which we will come back to, but you will be able to look at it because it's quite a long one for you. And I'm really delighted to introduce Nigel Crisp as the co-chair with Sheila Toulouse of Nursing Now, a campaign to celebrate nurses worldwide. But as I said also, I think someone who has done so much to promote to countries like Europe, like North America, that we so-called rich countries can learn so much from the so-called poorer countries. And we have, and I think Sheila's talk showed a number of areas where Botswana has really focused on change and where we, certainly in this country, still have so much to do. Nigel, can I invite you to take the floor?
Thank you very much indeed, Christine. Well, brave and bold, great words, great description, and what a fantastic story. And can I say what a pleasure it is to be sharing this virtual platform with two great and inspiring women leaders like Christine and Sheila. A real pleasure. You can imagine it's a pleasure being co-chair with Sheila of Nursing Now. We do it in an inclusive fashion. You'll have spotted that she's a nurse, I'm not a nurse. She's African, I'm European. She's a girl, I'm a boy. She's extrovert and I'm an introvert, of course. So it's a really interesting combination, but we seem to make it work, don't we, I think, Sheila, and has been great fun. I'm going to talk briefly about Nursing Now and about its legacy, and then go on into non-communicable diseases and just a little bit on my latest book, which you kindly mentioned earlier. So Nursing Now, why did we, and actually before doing that, let me also just join Sheila in paying tribute to all the people who have suffered and are suffering, nurses and others and relatives in this really difficult, awful time for just so many people all over the world. Really important that we keep remembering that, and actually that as we have these sort of conversations about the future and about building back better, you know, some of that's a tribute to the people we've lost as well. So let me turn to Nursing Now. We set it up 3 years ago, and let me just tell you why we did it. I mean, I'm not a nurse, as I say, but I realized from some work we did that just how important developing and supporting nurses would be for improving health globally. In fact, one of the points I now make, if talking to ministers of health elsewhere who say, what have I learned from my experience about what we should do, top of my list of things we should do now is empower nurses. Nurses, all the research shows us, are too often undervalued and underutilized, not able to work, they're busy, but they're not able to work to the top of their abilities and to be able to do everything that they're trained and want to do. So as a non-nurse, my approach to all of Nursing Now and why we set it up was a realization this is one of the biggest things we can do to improve health globally. And that's why our slogan, as it were, is we're about raising the profile and status of nurses in order to improve health globally. Grateful thanks to Burdett, the Burdett Trust for Nursing, and I see Anthony Gormley, one of the trustees, is on the call. Really grateful to them for taking a punt on us and supporting the campaign from the start, which has been really valuable for us, and great tribute as well to the International Council of Nurses and to WHO, who've been our strong partners. Now, Nursing Now really took off. We didn't have terribly much money. We had enough to run the sort of basis of it. But there are now, 2.5 years on, 750 Nursing Now groups in 126 countries around the world. And even during COVID, this has continued to grow. Russia actually launched Nursing Now Russia about 4 weeks ago, with a video event which actually involved 3,000 people across about 4 time zones, and the Ministry of Health in Russia as well. So this has really taken off as as something that is trying to promote and develop nursing. And of course, COVID has really shown to the world, I think, just how important nurses are in every role, from the most intensive right the way through to community and tracking and tracing people everywhere. So I think there's a big emphasis on raising the profile and status of nursing. We have decided, because of COVID, we were due to finish at the end of December, but in fact we're going to finish at the end of May next year with the World Health Assembly, which will no doubt be a virtual event. But we have also been managing our legacy. The first thing is that those groups that I referred to, the 750 Nursing Now groups, we're asking them if they would like to transfer and be supported by ICN. So hopefully they will continue to develop and to support everything else that's going on. The Nightingale Challenge, which is our development program, which has currently got 30,000 young nurses and midwives involved in it. We are working now optimistically, and I'm pretty sure that we will be able to extend that for another couple of years, because it has been so successful in bringing together all those young nurses and midwives. And of course, we're going to be doing a report on this at the end of May. It won't be an evaluation, because actually I think you can't evaluate the impact of this for something like 10 years. So it's much more a report on what we've been doing. But it is good to see that there's already been local impact. And I point to countries as different as Pakistan and Uganda, where they have had enormous political support and where there is increased investment in nursing, because people like me, non-nurses, recognize that this is probably the biggest thing you can do to improve health globally. And there's enormous energy out there and positivity. Although, let's be clear, at the same time, I was talking to nurses in Spain yesterday, there is, people are exhausted. And as the second wave moves around Europe, I can see how difficult this is. Let me translate that through then. So Nursing Now will continue in various forms, activities will continue. Let me move that on to NCDs. One of the things that we have very much promoted through Nursing Now is nurse-led NCD services. Long-term conditions need to be nurse-led. Nurses, of course, are the health professionals who are in their initial training to get a biological, a psychological and a social view of the world. And they are the people who very often manage, or generally manage, the continuity of care for people. And they are perfectly placed, it seems to me, to be managing long-term conditions and chronic diseases and non-communicable diseases. And we see that all over the world now. We see in my country that diabetes services are very often run by, and COPD and various others are being run. We see nurses in Tonga who are running and developing the services in Tonga. We see nurses running these sort of programs and services everywhere. And I believe that we will see nurses playing an even bigger role in primary care in the future. And the sort of model that is developing in a lot of Africa, where you see nurses in the clinics, the first professional that people meet, the first health professional that people meet is a nurse, and they are managing community health workers further out into the smaller parts of the community and more remote areas, and then linking into the hospitals, which is by and large where the doctors are, and they're doing that electronically as well as otherwise. So one can see that there are enormous scope for the development of nursing here, but that development will also be about managing and working on prevention and creating health in the context of non-communicable diseases. So let me then just finish with just a couple of minutes on my new book, which was kindly mentioned, and which I can put up on the screen, but which has got a saying from my great friend Francis Omazwa, an African leader of the Ugandan Health Service at the beginning of this century. It says, "Health is made at home, hospitals are for repairs." And it's a great saying for a lot of reasons. And it's not just about transferring services from hospitals to the community. It's that idea that health is made, that you can create health, that you can think about the causes of health and not just the causes of ill health. And I know we are constantly encouraging people to be thinking about prevention and stopping disease, but actually there's also something here about creating health and about creating, helping people grow up to be resilient, healthy, strong, independent people within their communities. The World Health Organization definition of health from 1948 is that it is physical, mental and social well-being. Well, we've concentrated, particularly in the West, but I think all over the world, on the physical well-being. We're getting better at thinking about the mental well-being, but we really do need to think about the social well-being, and the importance of our relationships, the importance of our environment, the importance of the structure of society, and how all of that can affect us for bad, but how all of that can also affect us for good. And the sort of health and what I describe in this book is people who I call health creators, who are the people who are helping develop, helping create health, helping create the conditions in which people can be healthy and helping them to be so. And not tackling individual diseases, not preventing individual diseases, not doing the sort of the caring and the treatment, but actually helping create the society in which people can be healthy. And in the longest tradition we're talking about here, it goes back to the ancient Greeks, who spoke about something called eudaimonia, which is often described as human flourishing. And I think when I think about health now, I think that our goal is about human flourishing. It's about great health services, it's about great prevention, but it's also about creating health, and those three things together. And let me finish with an example of a nurse, because actually some of the leaders in this field are nurses. You won't be surprised to know. Let me talk about somebody who will be known to, I think, many in the UK, Heather Henry, who's an independent nurse entrepreneur, as she styles herself, working in the north of England. And a few years ago, she was working with a community to try and help it to be more healthy. And she realized that actually, that in the community, there were some completely unused assets, if you like. And what they were the unemployed men in the place. Now, normally you might often tend to see that purely as a problem, but actually she started to work with these unemployed men who were perfectly, able-bodied men, mostly, and there in the community during the course of the day. And she started to work with them and encourage them to develop their own organization called Salford Dads, as it happens, DADZ, and which started to develop and undertake community activities. And what was interesting is over the period of that, you could see that within that community, there were improvements in the health indices, there were improvements in a number of ways that were measurable, and there were also, of course, improvements for the men, and many of them actually ended up getting jobs, or many of the original men involved ended up actually getting jobs because they'd built up the confidence, they built up the strength, they built up the resilience for the future. So I do think that as we move forward and thinking about NCDs, which I know is the absolute focus of C3, that we should also be thinking not just about the prevention aspect, not just about the treatment aspect, but also about creating the sort of communities where humans can flourish, where individual health is linked to community health and to society health. So thank you very much indeed.
That spoke really strongly to C3's vision, which is that people should find it easier to live healthy lives. So hopefully with two such inspiring presentations, we'll have several, we're getting lots of comments in the chat. We've a couple of questions. And I'll invite the people who posed the questions to speak. So first of all, I think Georgina Kate Adams has a question specifically targeted to Sheila. Georgina Kate, are you able to ask your question?
Hi Sheila, can you hear me?
Hi Georgina, yes.
Hello. Yeah, I was really interested to hear about all of your work in Botswana.
I've read your question, yes.
Oh, you read my question. So yes, shall I repeat it or?
You can repeat it in that I also have, I'll be able to clarify a few things.
Okay, fantastic.
Yes.
Yes, so I haven't worked in health in Botswana, but I have done some, I have visited the country. It's a lovely country, and spent some time with the San Bushman people and done some research as well into their life. And I'm very aware of how They are very much a marginalized group within the country and have been resettled in recent years. And as such face quite specific health inequalities. Particularly, I'm aware that in resettled communities, there's big issues with alcoholism, drug abuse, HIV, and so forth. So I'm interested in whether the SAN would be a group that you would consider to be like a key population, and what kind of specialist attention and care they may need or are or aren't being provided.
Yeah, thank you very much. Thank you very much, Georgina. I'm sure, you know, when you say talking the SAN, you are talking the specific community, because there are quite a number of SAN communities in Botswana. Actually, I am a descendant of the SAN myself. The SAN who settled in the villages and therefore went to school and married, and you know, I'm a third generation of them. As you can see how light I am. So that I mean, I take it you are talking about the ones who were moved from the Kalahari and resettled in some areas where, you know, because of lack of, what should I say, to do and, you know, the way of life, they were then exposed to all those. But in some of the communities, I'm not too sure what community you're in some of the communities, actually, they have family welfare educators among their own, usually just to train one of their own. Although I must admit that sometimes, okay, we are going to give scholarships. As you are aware, Botswana is one country where education is completely free, all the way from up to university and beyond. So that you then target the SAN children and say, they're going to go to school and they have mobile schools for them. And they're going to then come back, you know, as graduates, as nurses, as whatever, to help their communities. But once they've graduated, they don't want to go back there. Whether it's those who are resettled or even the ones that are still left in the Kalahari, because they say, we also want to be in town. So that has been a problem, but indeed, you know, they have that right to access. And when I was minister, we had family welfare educators, and we actually had clinics, some of them mobile, that were, you know, staffed with community healthcare nurses, especially because we knew that HIV/AIDS, they were not immune to it. And if you are aware of the SAN, I mean, anytime. So we knew that once one of them was infected, it was bound to actually go anyway. But I must say that during my time, we were able to ensure care to them and really reach the rural areas, those remote areas, to the point where my very first successes, where I would go to a community and say, has there been any child who has been born HIV positive in the past 6 months or a year? It would be none. It was actually from those communities. So that that's what happened. But as I said in my presentation, 10 years after I left, a lot of things happened, as you say, under the current regime. Nursing training went down, and therefore not a lot of nurses were posted in the rural areas. If you look at the State of the World Nursing Report, you find that Botswana actually has a different color from Africa, showing that our nurse-patient ratio is actually better than the rest of Africa. But during my times, it was even much better than that. We had community healthcare nurses all over. But now it went down, so that I am sure once it goes down in terms of you know, coverage, the most vulnerable would be the ones to be affected. So that, yeah, we're hoping that you know, more services will be to them, and they'll have even more care. But sometimes it doesn't happen that way. We're trying to, now we have a new president. We don't know what it's going to be like, but the past 10 years really did show Botswana went down in terms of healthcare. So, yeah.
Questions are coming fast and furious, and somebody.
I saw one on comprehensive sexuality education.
I've seen two from Patricia's iPhone, which I think I can identify. Pat, can you unmute and ask, maybe run your two questions together, and then I'll move to Colin Bullen. Pat, are you able to unmute?
I've unmuted Pat, so hopefully that'll work.
Unmute. Sorry, yeah, I think I'm unmuted.
You are. We can hear you loud and clear.
Excellent. One question to Sheila was, what are the key lessons from HIV and AIDS pandemic that nurses can use in addressing COVID-19, both in hospital and community settings. And then I had a question to Nigel, and that is, despite the UK having strong and excellent nurse leaders, why do you think there was no representation of nurses in the key groups that were originally set up in response to COVID? Why is it not obvious at this stage in this country that nurses would be key in such a situation? Thank you.
Okay, let me go to what are the key lessons from HIV/AIDS. There are quite a number. I'll go first to the community, in that's where my inclination is being a public health nurse. To simply say that, working with communities and really ensuring that health starts at home has been the lesson that we can learn from HIV and AIDS. The very first activists were the people living with HIV themselves. They empowered themselves and made sure that they worked with health personnel to really make their governments change. South Africa, for example, they've been able to sue the governments to ensure that they provided ARVs, something that would probably not have happened. So that, unfortunately for COVID, I don't know who the activists would be, whether it should be the elderly people, but I believe the nurses themselves can be the activists, really speaking for and telling the experience of those who are surviving COVID, especially the elderly people, those who are dying from COVID, and also of the nurses themselves, to say this is what we need. So I'm seeing that in some countries, but in other countries, for example, even PPEs, you get to a country, you ask the minister, how is the situation with protective equipment? And they say, we are fine. You ask the nurses, they say, we are having to reuse. Yet they're quiet. So that we need to therefore educate our nurses to be that assertive, that bold, and to be able to actually document. Half the time we are so busy, we don't have time to document, but that's all it needs. How many people were without PPEs in the morning in a certain ward, for example? So it's really that. That's the way we can be able to convince those who are responsible for that procurement to be able to work. Now, the other thing, of course, from the AIDS response has simply been that we were able to work multi-sectorally. And of course, I'm seeing that with the COVID response. We just, where there is no longer any professional territoriality. We're all in this together. I mean, that's a silver lining that I've seen in the COVID response, in that because we're in this together, nobody's saying, no, that's my era, that's my era. People are all there and they are battling to get rid of this past pandemic. So that it is a lesson that we have learned from the AIDS response, in that with HIV, we knew that nobody was immune. And therefore we could do it multi-sectorally and ensure that a doctor, a nurse, a lawyer, and whatever can come together and be able to work on that. So I think I'll stop there.
Thank you. And Nigel, the question that was directed to you, and then I'll go to Colin and then to Ben.
Unmuted, I think. Yep. Why were there no nurses on the initial COVID groups, which I didn't know whether there were or not. But I mean, there's no excuse, is the short answer to that. I mean, one can imagine all kinds of reasons. I don't know who put the groups together and so on. But there is a difficulty that there are several layers of difficulty of why nurses aren't necessarily the first people that people think of when you're dealing with an issue that immediately doesn't look as if it's all about nursing. And I think there is an issue here that nurses need to be involved not just in policy about nursing, and some of the senior nurse leaders get stuck in that box where they end up talking about nursing policy, as opposed to what Sheila was talking about, is nurses dealing with all the health issues and also not being territorial and not suffering from other people's territoriality. That's where we've got to get to. In the UK, we're obviously not there. It took quite a long time to get Ruth May onto those, for those in the UK, onto the tea time broadcasts that we had of what was happening, and she appeared a few times on that, as this is the Chief Nursing Officer. But it's still very disappointing that we haven't seen that. But, you know, I think, Pat, you can probably guess the reasons just as well as I can. But I say there's no excuse, and it's partly why Nursing Now is here and advocating for raising the profile and status of nursing, because it will feed through into improved health. And
a nice quote from Carol Baldwin, and I remember hearing Shirley Chisholm say as well that if nurses aren't at the table, they're on the menu. Colin Bullen, a question, and then to Ben Sims. Colin.
Christine, hi. It's really good to see you again, and good to be back. I haven't been here for a while, and just thanks to you and to C3 for putting together another fabulous session. This is really inspiring, and thanks to Nigel and Sheila as well. My questions were, and I just had to pick up on Nigel's piece about keeping the vision in mind here. It's very easy for particularly the caring community to go into fix mode and solve things, and keeping that vision of human flourishing in mind as we think through all these issues and the role that nursing can play in that, I think is critical. My questions were practical ones. We deal in behavior as an organization, and the things that need to change in order for these things to come to fruition. And I wanted to get into the things that we should do differently. And Sheila's concept of this brave, bold community is right. There's lots of skills and wealth of knowledge there that we need to bring forth. What needs to change to allow that to happen? You know, there's many environments have a fear of speaking up, and you know, some of the things that go wrong are just been illustrated by Pat's question with regards to UK response to COVID. So what changes would you like to see, and what messages should we be giving to those in positions of power in the health systems around the globe to allow the voices to bubble up more naturally and to become heard alongside all the others?
Okay, can I start with that?
Please do.
Yeah, well, I mean, for me, being brave to bold has a prerequisite. You can only be brave to bold if you know what you're talking about. You are not talking opinion, but you are talking evidence. So I was one of those brave nurses because I concentrated on doing research, no matter how small. It then became data that I could take to either the head of state or to the matron or to whoever is my superior to say, this is what I found. It would be great if you could do this as a result of it. So that I think that's basically that we need to empower our nurses with their power to be able to collect data and use data for influencing changes in policy, changes in whatever, even in governance. So that's basically that. Now, when that happens, it's then easy because once it's published, and you know, I'm not even talking publishing in international journals. I used to say to my students, what do we have? And I say, you know, the Sunday paper, we're gonna send this. Somebody's gonna read it. And that's exactly what would happen. So that it's, as long as somebody can, there's always that person who is interested, who say, let's come and talk. So I would say to leaders out there to say, don't leave the nurses behind. The power of nurses is very important because they are usually the ones at the community level. They are the ones that the people trust most. Therefore, you leave them behind, you are basically killing yourself. And that's what I'm seeing right now in my own country, Botswana. Right now, we have a COVID task force, which I volunteered to, by the way. I was right in Johannesburg and I said, I phoned our president and said, I'm available, I'm no longer traveling. So I can be able to serve in the COVID task force. So it was like, oh, that's really great. We'll get back to you. But guess what happened? Then it was all male technocrats who were appointed into this COVID task force, loading down on people and telling them when they're going to lock down, when they're not going to lock down, and having people get permission to go anywhere through cell phones. How many people have cell phones? You know, as Georgina said, can the Kunsang be able to get cell phones somewhere there that are working to get that permission to be able to go even to the hospital? So you saw males doing decisions that had nothing to do with what's basic on the ground. And that's what happens. So now the epidemic is rising, but I'm hoping that they are now getting that thing, because now at least there's been a director who's a female who's been appointed. I'm back now in Johannesburg because at least I'm able to do a few things. But basically it's really that, to say, let's be more grounded on the reality of the people's experience. And in there, we'll know that the nurse is very important in that. Yeah. Great.
I'm going to ask the last two questioners to go together and invite Sheila Nigel to answer Ben's question because it's directed, and Sheila to answer Jessica's question. And as you answer, perhaps you can also say a few words to sum up. And I'm conscious that we're dead on 6:30. If anybody's got their dinner in the oven or in North America needs to go back to work, we won't complain, but we've two really interesting questions to end a fascinating session. So Ben, can you ask your question of Lord Crisp?
Very quickly, and congratulations, the scale of what's being achieved with nursing now is so impressive. I was interested in the evaluation and how that might help us understand that legacy and what your ambitions for the use of the evaluation would be.
Great, thank you, Ben. We're not doing an evaluation, we're doing an end of term report, if I may put it like that, because actually we don't think you can evaluate this for 10 years, probably. I mean, I hope that the impact of the Nightingale Challenge in nursing now will be in the longer term over many, you know, as many people develop and do things. But the report will draw out lessons, Ben, as you say. It will draw out the examples of when I mentioned Uganda and Pakistan, didn't I? And it will end up making some recommendations. But we've got it being done by the School of Nursing at the University of Edinburgh, and it's going through, you know, so that, and they are doing surveys and asking questions and gathering evidence and so on. But it would be wrong to call it an evaluation because there simply hasn't been enough time. But my last point then Christine, to make a sort of bigger point, which is about the and slightly respond also to Colin's question. Is nursing now isn't actually a nursing campaign, it's a health campaign. And that's actually rather an important point. We deliberately have not been dealing with nursing policy, we've been dealing with the impact that nurses have on the world and on health. And some of what is missing in terms of people having the chance to speak out or being able to influence stuff is that we do need to get people to recognize that connection, the data that Sheila talked about, but actually a bit more than just the data, that connection between high quality nursing and impact, and in ways which other people can understand. But it also relates to development and to confidence and to a whole range of other stuff. And I spent part of this morning talking with Barbara Stillwell, the director of Nursing Now, and colleagues, again about how we need to get more action on the development internally of nurses and their exposure to positions where they can be having that bigger impact. Thank you very much.
Great. And Jessica, leaving you the last question.
Oh my goodness, thank you. And thanks for squeezing my question in. I know we're over time, so I'll be as brief as possible. But thank you for this event, it's been fab. So I'm a newly registered nurse and I would really appreciate from our panelists what your advice is for both student and novice nurses who are keen to make change, lead, advocate on a higher level. They may have had that opportunity as students, yet when they register and enter the workforce, they're told that they must do their time before they're able to influence. And in no way am I suggesting that these students or novice nurses should sail straight into leadership positions, but how can they be supported to do this alongside their clinical roles without being told not to by others who are currently in their teams or within their trusts or workplaces? Thank you.
All right, I think that brings about two aspects. The first one being the collaboration between the academics, the ones who are, educating the nurses versus the people who are working in the clinical area. Sometimes there are actually two different dichotomies. And we need that exact collaboration, because if the people on, at the clinical level, whether it's community health or in the hospital, know that at university level or whatever institution of training, these nurses are being educated in leadership, in being assertive, in doing research. It's something that they know, and they should be able to then come back, instead of falling down, be able to actually say, we are therefore giving you, as part of your orientation, to use these skills that we have been taught. But I think there's still that, dichotomy when it comes to the clinical versus the educational area. So that's one aspect. But the other aspect that has been mentioned by my colleague Nigel is really the Nightingale Challenge. I'm hoping that as many employers as possible will embrace the Nightingale Challenge, because we are saying, let us focus and ensure that we invest in the next generation of nurse leaders. We should be able, therefore, to have employees who are well trained, but employers who then are able to concentrate on at least what we said, Nigel, our data. Listen, our mandate had been, we'd like employers to be able to select about 20 in that area, to be able to actually have leadership training for them, whether it's leadership at academic level or even within the institution. A lot of countries have embraced that. We now have over 30,000 young nurses who are within those trainings, but I think we need more, so that it's really then a question of, in your area, find out if your environment, your hospital, has not registered as part of the Nightingale Challenge. That's really what the future is all about. And therefore you'll be able to then have fewer people who say to you, wait your turn. I've experienced that when I was a minister, where even when a young nurse came after 2 years or whatever and wanted to go and do for a master's degree, they would be told, well, there are 3 people before you. And I'd be wanting to know, well, why are those people not at school? Well, they're still trying to write exams so they can qualify. And I say, and you are delaying somebody who already qualifies? I would simply say to them, go forth. And so that sometimes that hierarchy is there in nursing, but that's the only way we can be able to break it, to ensure that we have leadership training for young nurses. So with that, in my closing, is simply to say nurses can do a lot. Through Nursing Now, the Nightingale Challenge, and of course, the beyond of the Nightingale Challenge, we're hoping that we will be having nurses who can be able to participate and be effective in all the 17 Sustainable Development Goals, not just Goal 3. And indeed, nurses who can be advocates, who are bold and brave enough to be gender advocates in all the 17 goals, not just the 5th one, which calls for gender equality. So let's simply go out knowing that we can do a lot, but we need to collaborate. As we already said, as part and parcel of COVID, we need to collaborate. We need to have more information across, disseminate information to each other. And once COVID-19 is over, let's make sure that we meet and talk leadership and a lot of things. Face-to-face is usually nicer than me sitting in some room in Johannesburg and talking about this. So it would really be great. Thank you so much. Yeah.
Sheena, thank you for coming all the way from Johannesburg to join us today. Thank you, Nigel, coming all the way from Oxford. And most of all, thank you all our participants for coming, for sharing such questions, but also lots of comments. I'd like to thank you all, but a very big thank you to Sheena Tulu and Nigel Crisp for a fascinating time. I can't say evening because it isn't evening for everybody, but thank you both very much, and thanks to all our participants. And stay safe, wash your hands, and don't get too close to people you don't know. Thank you. Bye.
Bye-bye. Thank you.
Thank you, Sheena.
Thank you, Christine. Thank you, Nigel. Talk to you soon.
Thank you, bye.
Thank you, Nomte.